Welcome to Healing Horizons. I'm Chris Daniels, your host, and today we're exploring the science of Ibogaine and how it may rewire the brain to support recovery, especially for veterans traveling to Mexico for care. We'll unpack where Ibogaine comes from, what happens in the brain, why withdrawal and cravings can ease, and how preparation and integration shape outcomes. I'll also cover safety, clinical standards, ethics, and the legal landscape, alongside stories of challenge and hope. As always, this is educational, not medical advice. Ibogaine carries risks and should only be pursued with qualified medical supervision in a legitimate clinic. Ibogaine is a psychoactive alkaloid found in the west central African shrub Tabernanthe iboga. In the Bwiti spiritual tradition of Gabon and Cameroon, iboga root bark is used ceremonially for initiation, healing, and meaning-making. Modern interest grew when individuals noticed profound reductions in opioid withdrawal and compulsive patterns. Today, clinical programs outside the United States use purified ibogaine, or total alkaloid extracts, to address addiction, trauma, and depression. The appeal isn't escapism, it's the potential to interrupt entrenched cycles while opening a reflective state where people can face root causes. Veterans often describe it as both demanding and deeply clarifying. After ingestion, ibogaine is metabolized primarily by liver enzyme CYP2D6 into noribogaine, its longer-acting metabolite. Ibogaine's acute phase drives the visionary, introspective experience. Noribogaine lingers in the body for days to weeks, subtly modulating mood, sleep, and reactivity. Many people report markedly reduced withdrawal, fewer cravings, and an easier time engaging therapy during this window. This is not simply numbing. Noribogaine appears to interact with serotonin transporters, kappa opioid receptors, and other targets that may stabilize affect and reduce dysphoria. For veterans detoxing from opioids or stimulants, that extended tail can create breathing room to build new routines and habits. At the systems level, addiction skews learning toward short-term rewards and cue-driven behavior. Ibogaine seems to dampen overactive dopamine reward signaling while normalizing glutamate via NMDA modulation, which can quiet the go circuits that hijack choice. It also interacts with serotonin transporters and nicotinic acetylcholine receptors, potentially reducing anxiety and interrupting cue salience. Beyond receptors, people describe a network-level reset. Default mode, rumination softens, executive control strengthens, and salience networks rebalance. In plain language, the brain gets a chance to step out of autopilot, evaluate consequences, and reassign value to long-term goals, relationships, and health-promoting behaviors during recovery for veterans. Another piece involves neuroplasticity, the brain's capacity to adapt. Preclinical work suggests ibogaine can upregulate neurotrophic factors like GDNF in dopaminergic regions and BDNF more broadly. These molecules support synaptic remodeling, dendritic growth, and healthier communication between circuits. Clinically, people often describe a palpable window of flexibility. New habits stick more easily, triggers feel less magnetic, and therapy lands deeper. For veterans, that window can be channeled into rebuilding mission, identity, and purpose beyond the uniform. While we still need human biomarkers to confirm these mechanisms, converging evidence aligns with the experiential reports of sustained change after dosing in many programs. Addiction and trauma are partly disorders of learning and memory. Ibogaine's on-irogenic, or dreamlike state appears to surface autobiographical material while reducing defensive avoidance. That can allow memories to be revisited and reconsolidated with less fear, updating their emotional charge. Conditioned cues, places, people, rituals may lose intensity as new associations form. Some veterans report sequences that feel like guided tutorials, reviewing decisions, seeing collateral damage, experiencing forgiveness, and rehearsing different choices. Others experience symbolic narratives that later decode in therapy. Not everyone has visions, but many describe a powerful shift from reflexive reactions toward reflective meaning-making, linked to personal values instead. A typical clinical session begins with fasting, hydration, and baseline monitoring. After test dosing, The main dose brings a gradual onset, body heaviness, sensitivity to light and sound, and ataxia, so bed rest is essential. The introspective phase can last 6 to 12 hours with eye shades and music. Nausea is common. Staff monitor continuously, including cardiac telemetry. As the acute experience subsides, many feel emotionally open yet physically tired for 1 to 2 days. The afterglow follows: clearer thinking, lower reactivity, and improved sleep. Gentle walks, therapy, and nutrition support consolidation. Most programs discourage abrupt decisions for several weeks to protect new learning. Veterans often arrive with layered challenges: PTSD or complex trauma, moral injury, chronic pain, mild traumatic brain injury, sleep disturbance, and grief. Substance use can serve as short-term armor that eventually corrodes life. In this context, intention setting matters. We ask, what does healing look like across body, mind, family, and mission? Goals may include interrupting nightmares, reducing hypervigilance, recalibrating pain, restoring trust, and rebuilding purpose. Programs in Mexico familiar with military culture can tailor protocols, coordinate with existing providers, and ensure trauma-informed care. Crucially, Ibogaine is a catalyst, not a cure. Ongoing supports are the backbone of recovery for veterans. What does the evidence show so far? Observational studies suggest Ibogaine can interrupt opioid withdrawal rapidly and support reduced use or abstinence for months, particularly when paired with aftercare. Data for stimulants, alcohol, and polysubstance use are promising but mixed. Emerging reports indicate improvements in PTSD symptoms, sleep, and mood, though the field lacks randomized controlled trials with long-term follow-up. Adverse events are real and underreported in informal settings. The takeaway: Ibogaine is not a panacea, but for some, it can open a workable window for change. Rigorous trials and standardized safety protocols remain urgent priorities across clinics and countries. Safety starts before travel. Comprehensive screening should include a detailed medical history, review of all prescriptions, over-the-counter drugs, and supplements, physical exam, resting and stress, ECGs with precise QT interval measurement, basic and comprehensive metabolic panels, magnesium and potassium, liver function tests, and, when indicated, echocardiogram or Holter monitoring. Clinicians must verify stable hydration, nutrition, and sleep, and coordinate taper plans when needed. During dosing, continuous cardiac monitoring, frequent vitals, and electrolyte management are essential. Post-session, watch for mood swings, insomnia, or hypotension. Candidates who cannot safely pause risky medications or who have unstable conditions should not proceed with Ibogaine. Red flags include personal or family history of sudden cardiac death, structural heart disease, prior arrhythmia, prolonged QT, uncontrolled hypertension, and active infection. Medication risks are significant. Methadone, many antipsychotics, certain antidepressants, some antibiotics, and antiarrhythmics can prolong QT or interact via CYP enzymes. Grapefruit matters too. Genetic CYP2D6. Poor metabolizers may have higher Ibogaine exposure, requiring extreme caution or exclusion. Recent cocaine or methamphetamine use increases cardiac risk. Dehydration, eating disorders, and electrolyte depletion amplify danger. Polysubstance dependence complicates stabilization. Programs should create alternative timelines or decline admission rather than push unsafe protocols. Lives depend on prudence and patience. Mexico's best programs operate like small hospitals. Look for an on-site physician with ACLS certification, experienced nursing, a cardiologist on call, and 24/7 coverage. There should be bedside cardiac monitoring, crash cart with defibrillator, airway equipment, IV access, and medications for arrhythmias, blood pressure, nausea, and seizures. Ask about transfer agreements with nearby hospitals and average transport times. Trauma-informed care matters. Staff trained in de-escalation, grounding, and culturally competent support for veterans. Transparent inclusion and exclusion criteria, informed consent, and clear cost breakdowns indicate professionalism. Avoid clinics that minimize risk, rush intake, or market miracle cures, or guarantee specific outcomes. Ibogaine comes as purified hydrochloride salt or total alkaloid extracts containing additional iboga compounds. Some clinicians prefer HCl for predictability, others favor TA for a broader profile at potentially lower doses. Dosing strategies vary: a single flood dose, staged sessions, or a test and titrate model for higher risk. Individualized plans rule. Preparation is just as important. Coordinate medication adjustments with prescribers, stabilize on nutrition and sleep, address infections or wounds, set intentions, and align family or unit support. Clarify roles for therapy, peer mentors, and medical follow-up before travel, so momentum continues the moment you return and supports sustained early gains. The 4-8-week afterglow is prime time for change. Schedule frequent therapy using CBT or ACT to translate insights into daily skills. For trauma, consider EMDR, prolonged exposure, or cognitive processing therapy with seasoned clinicians. Add somatic work, breath, yoga, tai chi, or physical therapy to recalibrate arousal and pain. Peer groups, recovery coaching, and family sessions reinforce accountability. Sleep hygiene, anti-inflammatory nutrition, and gradual exercise protect neuroplastic gains. Veterans can connect with VA or community resources for benefits, housing, and employment support. Measure progress weekly. Cravings, days abstinent, mood, sleep, pain, purpose, relationships, and meaningful community engagement tracked with shared plans. Before we close, a word on ethics. Iboga has indigenous roots. Respectful practice includes cultural humility, fair trade sourcing, and sustainability. Avoid sensationalism. Honor informed consent and patient autonomy. Legally, Ibogaine isn't FDA approved in the US, which is why many seek regulated clinics in Mexico. Ask for transparency and realistic expectations. A composite veteran story. Months of preparation, a demanding night, and weeks of steady work yielded fewer nightmares, mended relationships, and renewed purpose, alongside setbacks addressed in therapy. Today's takeaways: mechanisms, safety, preparation, and integration matter. This episode is educational only. Seek qualified medical assessment before considering Ibogaine in any setting.